you've been commenting here, well, basically your study is to look at what happens if you use radioactive iodine treatment for thyroid cancer. Can you explain to me what you were trying to do in this study? Why were you looking at this issue?
So, for a couple of reasons. One of them is myelodysplastic syndrome, we know now, is the most common myeloid malignancy in the US. We didn't know this before 2001. We only came to know this since 2003. And the reason is, before 2001, MDS was not even considered a cancer in our cancer registry. So there is no information at all outside of what is the risk of MDS in this patient population. The second thing why we looked at thyroid, why we picked thyroid cancer is we know that the thyroid cancer incidence is going up in the United States over the last 3 decades. We know that most of these thyroid cancer cases that are being diagnosed are kind of low risk because we are detecting smaller tumors. We also know from the literature that there is no clear benefit to using radioactive iodine in treating these low-risk thyroid cancers.
Yes, so you've got an effective treatment that's very effective when you have a tumor that's more advanced.
Yes.
But you've got the same screening problem that you go on detecting perhaps cancers which wouldn't have been risky.
And maybe you do not need to treat them with radioactive iodine in the absence of any clear survival benefit.
Right, so what did you do in the study?
So in this study, because of the challenges of detecting and capturing MDS cases after 2001 using the publicly available SEER software, we actually had to design an R program-based algorithm where we could capture as many MDS cases that occurred.
And did you?
And we did. So we created a novel platform, search platform called the SEER A-bomb. With that, we were able to capture about 100,000 thyroid cancer patients, and we were able to follow them, and we found about close to 50 MDS patients. Now, this number might seem low, but then MDS, although it's the most common myeloid malignancy, is still a very rare hematologic malignancy.
And it could be the tip of the iceberg?
It possibly could be. If you look at the risk evolution of MDS in this patient population, the first risk happens within the first 2 years. Now we don't know whether the risk is real. It could be real, or it could be that the people who got radiation, they were followed more closely by their docs.
Okay, so what have you in fact found in terms of the treatment with radioactive iodine and the outcome in terms of the risk of getting MDS?
So the early risk that happens within the first 2 years, we are not sure why the risk is going up that quickly. So what we are trying to do is we are trying to merge the SEER Medicare claims files with the SEER registry to answer that question. What we find is clinically intriguing and probably a little bit of concern is a trend towards increase in risk after 12 years from exposure. Now that could be a real signal, but we need to wait for a little bit more follow-up. And why I say that is because in atomic bomb survivors, we see that the MDS risk continues to goes up even after 40 years of exposure. So there could be a real signal in the second rise after 12 years of exposure.
Right. How might this knowledge influence the strategy for treating thyroid cancer, do you think?
Well, with this finding, I think it is important that both the treating physicians and the patients have a good discussion about what could be the potential late-term complications of the bone marrow in people who have otherwise low-risk thyroid cancer patients. Second, in patients who have been treated and have been cured of thyroid cancer, they should be under prolonged cancer surveillance. It doesn't need to be something separate or special, just annual surveillance by their primary care doctors or their treating physicians. And if you do see any blood count abnormality, please follow up on that.
So watchful waiting is a good thing to do in many of your patients.
Yes, and it can be integrated in the annual physical checkups. It doesn't have to be a separate surveillance program.
What about screening? Are we doing too much screening?
I'm not a thyroid cancer doctor, but what I know is there has been a push towards doing further investigations in people who have thyroid disorders. And when you use more sophisticated screening purposes like ultrasound, you will pick some small nodules or tumors that may not require anything more than just surgery. Because even the American Thyroid Association guidelines does mention to use this caution that in patients who have low-risk tumors, you may not necessarily need to do very aggressive treatment. Maybe surgery might be just enough.
Are there patients for whom no treatment would be a good option, just watchful waiting?
It would actually depend on what kind of histology you find when you do a fine needle aspiration of those tumors. Because a lot will depend on the biopsy findings. Okay, because sometimes identifying risk of thyroid cancer patients not only depends upon what is the pathology of the tumor, but also the age and other associated conditions.
Okay, so how would you sum up the clinical messages for doctors coming out of your report here at the American Society of Hematology?
Two. Basically, there are two take-home messages. First of all is there is a low risk but a real risk of myelodysplastic syndrome in this patient population based on the study we have done so far. We do not know exactly all the reasons behind this risk, but if we see it, I think it would be prudent for the treating physician and the patient to have a very free and frank exchange of the risks and benefits of the treatment that is being offered to them right now. And definitely in patients who have high risk thyroid cancer, radioactive iodine treatment is mandated because it does provide survival benefit. The case may not be that simple in low risk patients. Second, in patients who got radioactive iodine and were cured of thyroid cancer, that means they were disease free for more than 5 years, they should still be continue to follow with the primary care physicians. The key point is if you do notice any blood count abnormalities and you cannot find any clear reason for why these abnormalities are occurring, then you have to keep this thing in mind that these people have a low but a real risk of having a bone marrow failure condition even a decade or more from their treatment.